Good morning to all. Hope everybody is awake. First of all, I congratulate you people for attending a CME session like this. Usually we conduct this session for the postgraduates. So we'll have a 10 minutes introduction on varicose veins. You can close all the books, relax. What all I am saying is the textbook only. You can read Das or Bailey today and have some idea about it. Okay. So what is varicose veins? Yes, it's dilated and tortuous veins. Varicose means snake-like. Okay, when you look at the limb, you can see the snake-like veins, snake-like vessels in the leg, usually visible below knee joint. Sometimes, very aggressive cases, you'll get above knee joint also. Why there is with this gets vein dilated and largest in area? Yes. Okay, these veins are supposed to take blood from the periphery to the heart. Okay, from the heart to the periphery it's taken by arteries. There's a huge pumping mechanism, but for the vein there is no pumping mechanism like this. Okay, vein has to overcome the gravity and come back to heart, and the 2-3 major forces or factors which decides the vein to take back is the one is when we take breath, there is a negative intrathoracic pressure which sucks blood towards the heart. Okay, that's one factor. Second is vein have lot of valves. Valves which control, yes, next slide please. Yes, this is teacher. Yeah. Punitha's teacher, there was an accident a few years back. He's a very close friend of mine. Yes, this is what is varicose. Can you switch off the light please? Light, switch off the light please. This is the veins. Okay, this you can see that dilated veins. Usually it is not seen with, do anybody of you have these veins? No, this is not normally present, this is present in. So these are the veins which takes the blood from the periphery to the heart. One is when you take breath, there is a negative intrathoracic pressure, so it sucks the blood into it. Second thing is, have you traveled in a Rajdhani Express or a Vande Bharat Express train? Yes. Imagine the Vande Bharat which permit you enter the the posterior most of the back compartment and exit is possible only from the front compartment. Can you imagine it? So certain valves like that. That is just like veins. Okay. So the valves permit blood flow only to this towards upper part or the proximal part. Okay. It will not. This is valves like this. So when the blood comes from below, it goes up. So when I walk, what happens is the muscle contracts. The muscles applies pressure on these valves. Okay. When this presses, the blood jump from one compartment to other compartment. It cannot come back. Okay. This is a normal mechanism which happens. So 3 mechanisms. One is the valves. Second is the muscles. Third is intrathoracic pressure. When this gets damaged, anything which gets damaged, this varicose vein starts. Okay. So when this valve gets damaged, imagine the valve, there is a blood which the muscle compresses, jumps into the upper compartment, but the valves are not adequate. So when the muscle relaxes, the blood will go back to its position. Okay. So every time this happens, but some leak towards down because the valves are damaged. That mechanism is called a reflux. Okay. You remember one terminology, that is a reflux. That is the one reason why people get these veins. Okay. So when this reflux happens continuously, what happens is there is more and more blood accumulated there. And when the more and more accumulated there, what happens is the pressure goes up. Okay. The normal pressure at the ankle is around 10 to 12 millimeters of mercury. But there is multiple leaks, multiple sessions happens, more blood accumulates there. The pressure will go up and go up. Okay. So it can go up to 100 millimeters, almost equal to heart. Okay. That is called venous hypertension. Okay, that is second terminology. Remember, first terminology reflux, second terminology venous hypertension. And when there is venous hypertension, this vein is supposed to be a very thin walled vessel. Your dissection, you might have seen it, so you have seen veins. Very thin walled structure. So when the pressure increases, the blood will leak out. Okay, and when the blood is leaked out, it will get deposited in the cells around. Okay, so what happens is, the cells walls gets deposited by these blood components by heme and fiber and everything, and the walls gets obstructed. So no more transport of oxygen or nutrients or waste products across these walls. So what happens is it gets deposited under the skin. So you see that the skin becomes darker. Okay, that is why the varicose vein pupil, if you look at it, there is darkening of that skin below that. Okay. Good, good. Yes, next slide. Next slide. Next slide. Next slide. Next. Yes. Okay, forget about it. But if you see any varicose vein patient, you can see that there is black pigmentation, hyperpigmentation of this. And this is due to this reason. Okay. So reflex is one factor, hypertension, venous hypertension, and this leakage of blood to the periphery. These are the two issues. Okay. And when there is the cell walls gets deposited by this, everything was passaging through these vessels, the cells. When the oxygen, everything is not passed through vessels, what happens is there is hypoxia. Okay. So there is a tissue hypoxia happens. Okay. So these are three mechanisms by which varicose vein starts. Okay. This is the pathophysiology. So the symptoms are basically, one is pain. The classical pain is the patient is absolutely normal, he is lying down when he is walking, but pain starts when he stands. So what I say is when he stands, the blood gets accumulated there because the valves are incompetent, more blood accumulated. And when the blood is there, the vessel wall gets expanded. Okay, and this expansion causes some amount of pain. And this pain is very typical. When I'm standing there, I get pain. And when I start walking, slowly the muscle acts, so blood will be pushed up, so pain comes down. So the first steps of walking, there will be this pain. And initial part there's pain, but as the patient walks more and more, the pain is completely disappeared. But the arterial side, there is no pain during rest. The patient gets pain when patient walks, and more pain when the patient walks more. Here's the reverse. Okay, so this is called a pseudo-claudication. But arterial disease is called a claudication. This is pseudo-claudication because the process is reverse. So that's the commonest symptom. Commonest symptom is the patient having dilated veins. Most of them are asymptomatic. Okay, and the commonest symptom is pain, which occurs around the knee joint, happens more towards standing, and pain starts. Pain is there still on the first step, but he stops, walks more and more. The muscle gets acted, more blood is pushed up, the vein gets shrunken, the pain disappears. Is it clear? We have not much time to go, so a little hurry. So the next other symptom is they have blackish pigmentation due to accumulation of these waste products. Okay. And the third problem is they get ulcers. They get ulcers which is non-healing, which lasts for years and years. And the commonest, because I'm standing like this, by maximum pressure is where? At the ankle. It is not in the toes. Okay. So when I'm standing like this, maximum venous pressure is in the ankle. So most of these ulcers happens around the ankle joint. Okay. These are the common symptoms. The signs are basically, we have three, four tests. For your level, it's very important, but for when you are becoming a PG, it is less important. The things will change. Okay, so at least you should remember 3, 4 tests. With that test, you will stop it and will go to a case. Okay. The tests are classically, before that, some anatomy. We have 3 types of veins in the leg. One is the deep vein, second is superficial vein, and perforators. Okay. Deep vein is the larger veins. We cannot see it. It is inside the leg. Okay. Superficial vein, which is seen, we have seen there are 2 types of superficial veins. One is great saphenous system and the short saphenous system. Great saphenous system starts from joining the medial part of the venous arch, goes up behind the middle malleolus, along the middle part of the leg, which goes and which enters the femoral vein at the inguinal region. Okay. Short saphenous system is something which starts from joining the lateral venous arch. It goes behind the lateral malleolus, goes up and up. It joins popliteal vein usually, but not always. It can join at popliteal vein or femoral vein or any level above the knee joint. Okay, it's an inconsistent level. There are some veins called perforators. They are called perforators because it perforates deep fascia, and that connects the deep vein to the superficial system. Perforators have a valve which permits blood from the superficial to deep system. Okay. Otherwise, the superficial will dilate like this. Okay. So the perforator permits blood only from superficial to deep system. Classically, normally, it should not permit blood from deep to superficial. Okay, that's the perforators. So the tests are basically the most important junction of this superficial and deep system is the saphenofemoral junction seen here. Okay, it is almost 2.5 centimeter below and lateral to pubic tubercle. Okay, there is a great saphenous vein drains into the femoral vein. It has a very strong valve. That is the most important valve in the venous system in the lower limb. So our first test is to assess this valve is adequate or not. Okay, that's called Brody-Trendelenburg test 1. Okay, that how do it? You ask the patient to lie down, raise the limb so that the vein gets emptied, and you obstruct that saphenofemoral junction with your thumb or a tourniquet. Okay, keeping like this, ask the patient to stand up, release immediately. What will happen? Nothing should happen if they have a normal valve. Okay, so once you release it, nothing should happen. If something happens, it's abnormal. What something happens? Yes, the blood will come out of deep system to super system. That's a reflex. Okay, so that the super system will gets dilated, but very difficult to see in many patients. But classically, the super system gets dilated. Okay, that is how the Brody-Trendelenburg test 1 is done. So test shows whether the saphenofemoral junction valve is competent or not. Is it clear? Any doubt? I know I am a little faster for you people. So second is, so this valve is patent or not. Second is you have to see whether perforators are patent or not. Okay? So that's again the same test. Ask the patient to lie down, elevate the limb, empty it. Again you keep the same pressure at the same time. But here ask the patient to stand up and don't release it for 30 seconds. Okay? 30 seconds. And with that, this is getting obstructed. If this veins gets dilated, that means blood is coming from some other point. That is perforators. Okay? So if it's normal, blood should not collect from below up also. Okay? If it's abnormal, blood will be collected. Okay? That is test 2, which tests the competency of the perforators. Okay? Is it clear? Okay? Second test is, when we are treating as varicose vein, we are removing the superficial system. Okay? Then how the blood will goes up? Through deep system. Okay? So we have to make sure that the deep system is patent or not. That's very, very important. That is called, you have a picture? Yeah. Yeah, so that is pigmentation. You can see? That is pigmentation. Yes. Okay. So next is Perthes test. It's a modified Perthes test. That is, you ask again the patient to lie down, elevate the limb, vein gets emptied, and you apply a tourniquet just below the saphenofemoral junction. Yes. Okay, wait. So this is it. You apply a tourniquet here. Okay? You apply a tourniquet here so that this tourniquet will obstruct the superficial system. Okay? Tourniquet should not obstruct the deep system. Tourniquet should not obstruct the arterial system. Okay? It should not be very tight, should not strangulate. Okay? You just apply pressure and keep it like that. Then you ask the patient to walk for 30 seconds to 1 minute, or ask the patient to do some tiptoe movement if the patient cannot walk. Do like this. Okay? And then you check the veins. If it is normal, even though this gets obstructed, blood will flow up through the deep system. Okay? If deep system is normal, blood will go up. If the deep system is occluded, the blood cannot go up. So what happens? The blood gets accumulated in the superficial system. So patient develops pain, patient develops discomfort, and a dilated superficial system. That shows the deep vein is obstructed or not patent. Okay? So this is a very important test. You should do it. Okay? The third test is multiple tourniquet test. I said earlier there are perforators. Okay? There are multiple perforators. We should see which all perforators are normal or not. Okay? How will you see it? You apply multiple. Yes, this is multiple tourniquet. Thanks, Dr. Purudan, for wonderful slides. So this is you apply tourniquet at different points. How many tourniquet can apply? Any number of tourniquet. If you have 40 tourniquet, you can apply 40 also. If you apply closer means, that means you can identify exactly which perforator is abnormal or not. Okay? So there is no rule that you can apply 3 or 4 or 5. You can apply any number of tourniquet. Only thing is the tourniquet should not obstruct the deep system and the artery. Okay? Should obstruct only the super system. With that, again you ask the patient to do some tiptoe movement or walk around, see it, and if any vein is dilated between any two tourniquet means that perforator is incompetent. Okay? So these are the 3 major tests. You should not forget these 3 tests. One is Broyton-Lambert 1 and 2. That's 1 is for the subphalangeal junction, 2 is for the perforators, then modified Perthes test for the deep vein, and the multiple tourniquet test to identify which all perforators are abnormal or not. Okay. Can you have an idea? Got it? Any doubt? So now we'll go to the case. Okay. After the case, we will discuss the management. Okay.
This is the way you should tell the diagnosis.
Yes. When you present the case in the exam, you should give site, which side lower limb is involved, which site is the site of lower limb, below knee or above knee, whatever it is. Side is very important. Complicated, uncomplicated. Any complications present, that is obstruction, some ulcerations, pain. So different complications can be there. Third thing is primary or secondary. We will come to it once the case is discussed. Okay. So you are presenting it.
Good morning to all the professors and everyone present here. I'll be presenting a case on varicose veins. A 70-year-old male from Kalingarajapuram who previously worked in a petrol bunk for 15 years is now a coir rope maker for the past 10 years. He came with the chief complaints of dilated and tortuous veins in the right lower limb for 2 years and pain in the right lower limb for 2 years. So this is the image of the patient. He has dilated and tortuous veins in the right lower limb. History of presenting illness, history of dilated and tortuous veins which was insidious in onset. Initially the patient noticed it in the inner aspect of the lower leg, which then gradually progressed up to the inner aspect of the upper thigh. The veins became more prominent on prolonged standing, usually at the end of the day, and less prominent on lying down. History of pain in the right lower limb for 2 years, which is sudden in onset and progressive in nature, which is an intermittent type of pain with dull aching character. It got aggravated on prolonged standing, usually at the end of the day, and relieved on taking rest, particularly with elevated limbs. History of itching of the right lower limb for the past 3 months, and history of pigmentation in the right lower limb for the past 3 months. There's no history of edema of the lower limbs. There's no history of night cramps, ulcers in the lower limbs, fever, trauma, abdominal distension or constipation. There's no history of prolonged immobilization, chest pain, hemoptysis or difficulty in breathing. Past history is a known case of diabetes mellitus for the past 20 years and on regular medications, and a known hypertensive for the past 3 years and on regular medication. There was history of coronary artery bypass graft done 15 years back and was hospitalized for 15 days. There is no history of tuberculosis, asthma, epilepsy or any drug or food allergy. Treatment history, there is no history of usage of any compressive stockings. Personal history, patient consumes a non-vegetarian diet, not an alcoholic, not a smoker. Normal bowel and bladder habits and normal sleep pattern. Family history, total number of members in his family is 6. He lives with his wife and he has 4 daughters. There is no similar complaints among family members. So summary, 70-year-old male who is a known hypertensive and a diabetic with history of coronary artery bypass graft done 15 years back, is a coir rope maker by occupation. For 10 years, he came with chief complaints of dilated and tortuous veins in the inner aspect of the lower limb for the past 2 years, which is associated with dull aching type of pain, itching and hyperpigmentation for the past 3 months. So probable diagnosis is varicose veins of the right lower limb. Moving on to general examination, patient is cooperative, moderately built and nourished. There is no pallor, icterus, cyanosis, clubbing, no generalized lymphadenopathy or no pitting pedal edema. Height of the patient is 168 centimeter with weight 50.
History will some points. Something different. You said there is some peripheral artery disease also in this patient. Coronary artery disease, undergone CABG. What significance of this patient? Does it make any significance?
So the graph will be taken from the great saphenous vein. So
okay.
So there will be no SFJ junction. So in case if there has to be any varicosities, it will be seen in the distal part.
So, why there is varicose vein then? If the graft is taken, the total vein is
Graft is
taken.
taken from the left limb, sir. He has varicosities in the right limb.
Right side, okay. Okay, one thing is, then any other importance?
He might have any coronary artery disease, atherosclerosis.
Okay, that's a different pathology. The vein is a different pathology. Then, any importance of they having arterial disease? Yes. Burgers causing coronary disease is very, very rare. It's very unlikely. It's not. It's a good thinking, but Burgers doesn't cause much coronary disease. Any patient with a varicose vein, you should look for the peripheral pulses. Okay, that's very important because of two reasons. Because varicose vein management is there is called compression therapy. You know about compression therapy? We do compression stockings, we do bandages, we do four-layer bandage. So some sort of compression is there because the blood is accumulated there. Okay. So when there is compression therapy, you are giving compression therapy. If the artery is compromised, so that can produce gangrene. Okay. So anybody who is having a varicose vein, you are planning for a compression therapy, you should look for the peripheral pulses and always ask about the artery disease also. Second thing is, as she said earlier, that side vein is taken for treatment for coronary bypass. Okay. Sometimes they may need the vein for further treatment. So if that vein is normal, you think twice before you are removing the vein as a part of treatment. Okay. So because of these two reasons, when there is varicose vein, if the patient has a history of peripheral artery disease, we should be a little careful. Okay. Yes. So the common in this session, the symptoms are
Dilated and tortuous veins with dull aching type of pain.
Yes. So he has dull aching pains with a pain with a dilated veins. The reason I have discussed earlier. What are other features, other ulcers? You have any ulcer?
There is no associated ulcers.
There is no associated ulcer. Proceed.
Moving on to general examination, patient is cooperative, moderately built and nourished. There is no pallor, icterus, cyanosis, clubbing, no generalized lymphadenopathy or pitting pedal edema. Height of the patient is 168 centimeter with weight of 58 kg. BMI is 20.54. Vitals, temperature is 98.4 Fahrenheit. Pulse is 82 beats per minute, which is regular in rhythm, normal in volume, no specific character and no radiofemoral delay. Blood pressure is 192/100 millimeters of mercury, measured in the left arm in supine position, and respiratory rate is 16 breaths per minute. Local examination of the right lower limb. After getting consent from the patient is examined in standing position with both lower limbs exposed from the umbilicus to the toes. So inspection, both the limbs are equal in size with no obvious deformity. Dilated tortuous veins are seen on the medial aspect of the lower limb, which extends from the medial malleolus along the anteromedial aspect of the leg up to the medial aspect of lower one-third of thigh. Pigmentation seen over the anterior aspect of the lower one-third of the limb. There is no redness, ulcers or scars seen. There is no thinning of skin, loss of subcutaneous fat, loss of hair, dry, inelastic skin, brittle nails or transverse ridges on nails seen. Palpation, there is no local rise in temperature, no tenderness and no lipodermatosclerosis. So the tests done are Brody Trendelenburg test 1. On releasing the tourniquet, the veins spill rapidly above downwards, which signifies symphyno-femoral valve incompetence. On doing Trendelenburg test 2, veins fill gradually from below downwards, which indicates perforator incompetence. On doing multiple tourniquet tests, dilated veins were seen between the second and third tourniquet, so which indicates lower leg perforator in Boyd's perforator and lower leg perforator incompetence. So here there is dilated veins seen between the second and third tourniquet, and in the second image the dilated veins are seen below the third tourniquet. Pratt's test, blows were seen at the level of below-knee and lower leg perforator sites, and Fegan's test, defects in the deep fascia were palpated at below-knee and lower leg perforator sites. Morrissey's cough impulse test, cough impulse seen at the saphenofemoral junction, which indicates saphenofemoral valve incompetency. Percussion Schwartz test was positive, and on auscultation no murmur was heard. Local examination of the left lower limb. On inspection, the attitude of the limb was normal, and there is a scar extending from the mid-thigh to the mid-calf on the medial aspect of the limb. Dilated tortuous veins were seen on the medial aspect of the lower limb, which extends from the medial malleolus to mid-calf. There is no pigmentation, redness, ulcers, eczema or scars seen, and there is no thinning of skin, loss of subcutaneous fat, loss of hair, dry inelastic skin, brittle nails or transverse ridges on the nails. Palpation, no local rise in temperature, no tenderness and low lipodermatosclerosis. Brody Trendelenburg test 1 and 2 could not be done. On doing multiple tourniquet tests, dilated veins were seen below the third tourniquet, which indicates cockpit perforator incompetency. On doing Pratt's and Fegan's test, there were blowouts seen at the level of lower leg perforator, and defects in the deep fascia were palpated at the lower leg perforator. On auscultation, no murmur was heard. On examination of the peripheral arterial system, all the peripheral pulses of the lower limb, femoral, popliteal, anterior tibial, posterior tibial and dorsalis pedis artery were palpated. An examination of regional lymph nodes, there was no palpable regional lymph nodes. Other system examination, abdomen, soft, non-tender, no palpable mass and no fluid thrill. Cardiovascular system, S1, S2 heard, no murmur. RS, there was normal vesicular breath sounds heard and no added sounds. And CNS examination, no focal neurological deficit. So 70-year-old male who is a known diabetic and hypertensive with history of coronary artery bypass graft done 15 years back came with chief complaints of dilated and tortuous veins in the right lower limb for the past 2 years, which is associated with dull aching type of pain, itching and hyperpigmentation for the past 3 months. On examination, dilated tortuous veins are seen on the medial aspect of the right lower limb, which extends from the medial malleolus to lower 1/3 of the thigh, which involves a great saphenous system with saphenofemoral wall below knee and lower leg perforator incompetency. There is dilated tortuous vein seen on the medial aspect of the left lower limb extending from the medial malleolus to mid-calf, involving the great saphenous system with lower leg perforator incompetency. Diagnosis is it's a case of bilateral varicose, secondary varicose veins involving the great saphenous system with saphenofemoral wall below knee and lower leg perforator incompetence in the right limb, and lower leg perforator incompetency in the left limb with CEAP classification of the right limb. It is C4A, ES, ASP and PR. The left limb it is C2, ES, ASP and PR.
Before it's prepared by you or the help of some faculty or PGs? Pardon?
I got help from faculty.
It's very excellently prepared at your level. With that, if I am the examiner, with this I'll make you to pass just reading this. Then all the questions will be there to increase the marks. Good work. Keep it up.
Thank you.
Why do you examine the abdomen?
Sir, it will obstruct the venous outflow to the thoracic cavity. So if
Thoracic cavity.
to the heart, sir, obstruction to the venous flow to the
But
heart.
at which level it usually happens?
At the level of formation of common iliac artery, L5 level, sir.
That's called?
Common iliac artery, occluding the common iliac vein is
May
called
Turner syndrome.
What is May-Turner syndrome?
Compression of the left common iliac artery by left common iliac vein by the right common iliac artery.
Yes, classical one. Different varieties are there. But that's one reason. Any other reason? Abdomen? Any condition which increase intra-abdominal pressure by any abdominal tumor, a pelvic tumor, ascites, all this can compress on the IVC or iliac veins can produce varicose veins. So it's mandatory to examine the abdomen in all the patients with varicose veins because any pressure there can produce varicose veins. Did you look the scrotum?
Yes, sir.
Why?
So because scrotum is also a site for varicosities.
So if they have a right side varicocele with right side varicocele or left side varicose, the left side varicose vein, what significance it is? That means there is some renal pathology which is on the particular left side. There's left side varicose vein. Always look at the left scrotum. If there is left side varicocele, it means there is some pathology in the renal vein or kidneys. Always be suspicious about it. Okay? You check that heart sounds. Why it is? Simply just have a stat, you put it there and S1, S2. Any cardiac condition can produce a varicose vein?
So tricuspid valve regurgitation.
Yes, exactly. Excellent answer. Tricuspid regurgitation or right side lesions can produce varicose veins, especially if it's a recurrent varicose vein. You treat the patient again, come back with the recurrence. Always do a auscultation of the echo is mandatory to exclude tricuspid regurgitation. Very good. Okay.
Management, sir.
So that all the tests of Napsika's, what I described is she has very wonderfully shown all the tests. Any doubts? This is for a class for you, not exam. Any doubts you can ask? Now we are moving to management part. Okay. Okay. How will you manage your patient?
So proceeding with specific investigations, a duplex scan is done with USG of abdomen and pelvis. And then routine investigations, complete blood count.
No, leave all. Anything important in complete blood count or something that?
No.
Nothing there. Okay. Then.
And then treatment and right.
No. Only ultrasound abdomen is done.
And duplex scan, Doppler can be done.
Yes.
Yeah,
Okay.
What will you look in duplex scan, venous duplex scan?
So in duplex scan, we can see the presence of any reflex. If there is any reflex, then the extent and the distribution of the reflex can be seen. And then any obstruction in the deep veins,
So
any pelvic obstruction.
if I do a duplex on you, there won't be any reflex?
Sir, I didn't get the question.
I am doing a duplex on you.
A
You don't have
normal
a
person,
varicose
will they
vein.
get a reflex or not? Normal person.
Will there be a reflex? Yes or no?
Yes.
Yes.
By
Then why it's important? If it's present in everybody, why it's important?
retrograde flow of more than 0.5 seconds.
Yes, 0.5 seconds. That is significant. The reflex is there in all the patients because it takes some time, some fraction of a millisecond for the valve to close completely. Okay? The initial part of valve closure, there is some backflow of blood. That is there present in all the people. If we do duplex of 100 people are sitting here, almost 99% will have some amount of reflex. But that is significant only if that reflex time is more than 0.5 seconds. Okay? Then that's important. Okay? Yes, done. So you look at significant reflex. If it's a perforator, what's significant reflex? 0.5?
1 second, sir.
No. Less than that. It's a smaller thing. 0.35. Okay? Yes, then.
Then we look at if there is any pelvic obstruction.
No, you're doing a Doppler. You are supposed to look at the inguinal ligament downwards.
Compressibility of the vein has to be checked for deep vein thrombosis.
Yes. So second thing is you have to see that your modified Perthes is right or wrong. DVT is very important. If the patient has severe DVT and you exercise the super system also, the blood will not go back. So patient will have severe edema and all the complications. Patient will be on your head. Okay? So you have to rule out DVT. So you have done a clinical test, but ultrasound is more significant. So you have to rule out DVT. One thing is, how will you rule out DVT?
D-dimer test can be done.
No, Doppler. You are doing only Doppler.
There will be no filling defect will be present, sir.
Illamma? No. Normally vein is compressible or not? Normal vein is compressible or not?
So compressibility will be absent if DVT is present.
Yes.
Then there will be no augmentation of flow if any distal
Yes.
pressure is
Very good. Okay.
Absence of augmentation and non-compressible vein.
So classically all the veins are always compressed. You put a probe and push it, okay, the vein gets compressed. The artery never gets compressed. Okay. So normally all normal veins should be compressible, and when the patient take a deep breath or do a Valsalva or you do some pressure of the muscles, that will be some augmentation on the phasic variation of the flow. So this should be there. Okay, so you put a color mode and do this, the blood will flow like this. Okay. If that is absent, that's again DVT. So non-compressibility and absence of phasic variation and augmentation are the signs of deep vein thrombosis. Okay, fine.
See, you are doing so much test, no ma? Broad Eastern Limburg 1, 2, modified Perthes. So everything you will be seen in duplex. So saphenofemoral incompetence, it is seen in duplex. Saphenopopulated incompetent, it is documented in duplex. All perforator incompetence, it will be documented in duplex. So everything will be deep vein patency also, See, all the clinical tests what you are doing to say your diagnosis, no, saphenofemoral incompetence, popliteal incompetence, perforator incompetence, as well as deep vein patency. Everything you can look in duplex, right? That is the purpose of doing duplex. See, the reflex is, how do they augment the flow? By squeezing the calf muscle or by doing Valsalva maneuver or doing dorsiflexion or plantar flexion. They come with a roaring sound. And the reflex come as a roaring sound. Like that it will sound. Normal vein flow is continuous or soft flow. When the reflex will be a roaring sound. That is that they will be able to listen. The duplex person who is doing the duplex, no, will be able to listen. This is the way they identify each and every perforator and then mark it. Another take home message, all saphenopopliteal junction is variant. It is not stable. So we have to mark the perforator, say mark the saphenopopliteal junction the previous day of surgery, so that during surgery it will be useful to identify the saphenopopliteal junction. We don't open the popliteal fossa blindly to identify the saphenopopliteal junction. These are all the role of duplex.
So you looked at the deep vein thrombosis, you looked at the reflex at the SF junction and the perforators. Anything else you look for? One more point. You're excellent.
Suitability of the vessel wall for various procedures.
Suitable vessel?
Suitability of the vessel wall for various procedures.
What?
For various procedures. What may various procedures?
For example, if chemotherapy has to be done, then
Or laser or what? How do you assess the suitability? How do you say that this vessel is suitable for surgery or this vessel is suitable for laser or radiofrequency ablation? Anybody?
Size of the vein.
Size of the vein. Size of the vein is very important, because if it's a huge vein, you cannot do a laser or a radiofrequency ablation. Okay. What happens is, the laser is a very thin fiber. Have you seen a laser fiber? At least in films you have seen very thin fibers, and you put the fiber inside the vein. If it's a very huge delta vein, the laser is very thin and the vein is round. What will be there in between? Blood will be there. And if you apply laser, this blood will thrombose. Okay? And this thrombosed blood, if you pull out the laser, after some time, the thrombus may get dislodged and go up and cause pulmonary embolism. So that's a dangerous complication. Okay? Second thing is, you form a thrombus there, you pull out that laser and happily patient discharged. What happens to thrombus? Thrombus gets absorbed or thrombus gets dislodged. Okay? And that forms, once the thrombus gets absorbed, what happens? The same vein is there. So patient will come back to your OPD after 3 months with a recurrence. Okay? 3 or 4 months, whatever it is. So because of these two reasons, if it's a large vein, these procedures are not ideal. There are certain methods to do it, but at your level they are not ideal. If the vein is dilated more than 18 millimeters or so, the surgery is the treatment of choice at your level. Okay? Is it clear? So these are the 4 things. You have to look for DVT, you look for GSV size. GSV course, if the GSV is just like a hill highway, you cannot manage the wire through that. Okay? So that's also a relative contraindication to do it. So a straight pipe, you can pass the fiber. Okay? If it's very curved like this, just like the Karakoram highway, you cannot pass it. Okay? So that's the course of the vein and the size of the vein, DVT and the saphenophal junction incompetence. Okay? These are the things to be examined during the Doppler examination. Okay? So you have decided to treat the patient. So all our investigations are not required for varicose vein, CT angio. Nothing is required. Then do the blood test, everything for the patient is fit for surgery or not. I am not going to details about it. Time constraints. Okay, you have decided to treat the patient. This patient is symptomatic, patient has severe pain, patient cannot walk, and patient is at your OPD for treatment. How will you treat it?
So in the right limb, since there is saphenofemoral valve incompetency, Trendelenburg procedure with stripping of the vein is done.
Yes. What is Trendelenburg procedure?
So in Trendelenburg procedure, flush ligation of the GSV is done, ligation of all the tributaries, and stripping of the vein.
No. Trendelenburg never stripped. He is very decent. Yes. Third part. The concept Trendelenburg is stripping is later added to it, but stripping is not a part of classical Trendelenburg operation. Without stripping also you can do it. Anybody? Tremble procedure is you flush ligate the saphenophyseal junction. That is, flush ligation means don't take out the femoral vein, but don't leave more saphenous vein. You are close to junction as such. You ligate all the tributaries, whether named or unnamed or whatever it is, all the tributaries there. The third part is you will remove at least 2 to 3 inches of the saphenous vein. Okay? Stripping is something which I'll do it, but classical Lundberg is 3 aspects. One is flush ligation of all the tributaries. Third is remove the proximal 2 to 3 inches of the saphenous GSV. That's Lundberg operation. Okay.
How long you will strip? Up to what level you will strip the vein?
So only up to knee it has to be stripped.
Why? What is the reason?
If you go beneath that, then saphenous nerve injury can occur.
Yeah.
What happens if saphenous nerve is removed? You are removing saphenous vein.
If you injure the saphenous nerve during stripping, what will happen?
Sir, it supplies the cutaneous innervation of the
It's a sensory.
Sensory component.
sensory innervation of the dorsum of the foot. Sir.
Can do severe sensory impact.
Digit it supplies.
Right.
The patient is a film star.
சொல்லுங்க sir.
He doesn't want a cuts and something like that. So he's asking for other options. What will you do?
Sir, I didn't get the question.
Your
No,
patient,
patient want cosmetic procedure, not the open surgery. What are all the other options you can give?
Endovenous laser ablation.
Yeah,
and
endovenous
radiofrequency
laser and
ablation.
endovenous RFA. Radio frequency ablation and laser are available. What is the principle behind endovenous therapy? Principle.
So if if in endovenous laser ablation, the laser energy is transmitted and then it gets absorbed to release thermal energy. This thermal energy causes destruction
How much
of
temperature?
Destruction of what? That is the answer. Destruction of?
the endothelium.
Yeah,
sir.
correct. So endothelial damage done by the thermal energy
Or
is
laser
the
energy.
principle or laser energy is the principle behind all endovascular. When you give sclerotherapy, that chemical destroy the endothelium. The chemical that irritate the endothelium and destroy. And then here the thermal energy, laser energy, these are all the things which destroy the endothelium and produce fibrosis.
what's the temperature? It's by RFA maximum temperature.
120 degrees.
Very good.
Celsius.
Okay. So whatever be the aim, our aim is to produce endothermal damage, endothelial damage plus fibrosis, never a thrombus. Okay. More thrombus means the surgery is going to fail. Patient will come back to recurrence or land up in a embolism. Okay. Our aim is to produce fibrosis inside the cell so it gets completely obliterated. Okay. What is foam sclerotherapy?
In foam sclerotherapy, the sclerosant agent, that is sodium tetradecyl sulfate, and air is taken at the ratio of 1:3 and 1:4. Two syringes are connected by a 3-way tap, and then around 10 to 20 times they're oscillated between the 2 syringes, which causes a foam. So when we do foam sclerotherapy, the effective using a less amount of sclerosant, the effective volume is increased, and so the endothelial contact is also increased, so it is more effective.
It's an absolute contraindication for a foam sclerotherapy.
Saphenofemoral valve incompetence.
No, that's not a that you can apply some pressure and do it. Apply some. Still people are doing it.
Peripheral vascular.
DVT is a contraindication of many procedures. In fact, in DVT, this foam scler can be done in limited cases. For example, ulcer, just a perforator is there. That's the best option.
Peripheral vascular disease.
No. It goes up and up. What happens?
Pulmonary embolism. It causes stroke.
Stroke, pulmonary embolism. How it reaches the artery system? You are putting the vein. Yes. AV fistula where? What's the most dangerous AV fistula? When it happens in the heart. If the patient has ASD or VA put inject, that will go to cross system and go causing stroke and pulmonary embolism. So ideally you do at least you auscultate or you do an echo before putting sclero in this patient. Okay, the time is already, we have passed 20 minutes. Okay. Any questions, any doubt from your side? Any questions on varicose vein? She will answer. She is an expert.
What is CVMA? Chronic venous insufficiency.
So it is venous hypertension which causes edema of the leg. Edema of the leg with hyperpigmentation, lipodermal sclerosis, and a non-healing chronic venous ulcer.
See, the take-home message in chronic venous insufficiency, patient has to follow the Biscott's principle, that is elevation, elastograph bandage, and ankle exercise lifelong. It is controllable, not curable. Okay, all CVA are controllable. It is not curable. Okay, the patient should be advised lifelong gray bandage.